I don't think I come very often to the API meeting. It's my second API meeting, and I am sure I missed a lot hearing today's presentations and all. So, as usual, our normal OPDs, we are treating the usual cases 99.9%, and sometimes by luck, we get thrown with an interesting case, something which is out of the usual. And this is one such case where you almost think that you have the diagnosis as soon as you see the patient, but then the diagnosis turns out to be something else. So I hand over to Dr. Vijay. He's our final year medicine PG in DNB to present the case.
Good evening, everyone. I am Vijay Raghavan. I am from Medical Trust Hospital. I am doing general medicine. Today I am presenting an interesting case, TB or not to be. This is a 46 years old female who is a homemaker, resident of Ernakulam with a comorbidities of hypothyroidism and recently diagnosed ulcerative colitis. His main presenting complaints were cough with minimal expectoration. There was no relation with lying on supine, which was since 3 weeks. She also has dyspnea on exertion, which was gradually progressive from MMRC grade 1 to grade 3, which is also for past 3 weeks. And she also had complaints of fever, which was low grade, not associated with chills or rigors, which has mainly diurnal variation spikes during evening times, which was since 2 weeks. Negative history, there is no history of hemoptysis, chest pain, hematuria, decreased urine output, skin rash or hyperpigmental lesion, joint pain, stiffness, dry eyes, dysphagia. There is no intake of alternative medicine, no history of blood transfusion, no exposure to birds. So she went to a nearby clinic where he consulted doctor, general physician, where X-ray was taken and started an oral cephalosporin considering community-acquired pneumonia. But he past history, she was diagnosed with ulcerative colitis in October 2025, which was biopsy proven, and she was started an oral and rectal mesalamine. The dose was 2.5 grams per day, which is 400 mg 2 thrice per day. There is history of weight loss 10 kgs over the period of 6 months. She's a known case of hypothyroidism on thyroxine 50 microgram. There is no history of TB, diabetes mellitus, systemic hypertension, coronary artery disease, or cerebrovascular disease. Personal history, she's married, has 2 children, perimenopausal, a mixed diet, homemaker. There is no history of food or drug allergy, no history of smoking, alcohol, or drug abuse. No tuberculosis history or similar symptoms in family. So she came to our OPD, where in OPD initially TB was sent, suspecting TB because she had upper lobe bilateral consolidation, and TB gene expert was sent, which was negative. So initial DDs were this, considering the bilateral upper lobe consolidation: tuberculosis, community-acquired pneumonia, interstitial lung disease secondary to ulcerative colitis, drug-induced organizing pneumonia, hypersensitive pneumonitis, chronic eosinophilic pneumonia, sarcoidosis, silicosis, and Pancoast tumor. So, based on his history, we ruled out hypersensitive pneumonitis because there was no exposure to birds or something, and the history was subacute in nature. So, chronic eosinophilic pneumonia was ruled out, and there was no. She was a homemaker. There was no exposure to other things. So, silicosis was ruled out, and Pancoast was also ruled out because of the age and gender, and mostly it's unilateral. So, in OPD, TB came to negative. She was admitted because she was breathless, dyspnea grade 3. So, started an empirical antibiotic after ruling out TB, cephalosporin, sulbactam plus azithromycin, and cultures were stained from blood, urine, and sputum. TB gene expert once again was repeated. On admission, she was apyrexal, hemodynamically stable, tachypnic with 20 breaths per minute. On auscultation, lung revealed scattered crackles. Initial investigation showed leukocytosis, total counts of 18,000 with neutrophil predominance and anemia, hemoglobin 9.5 grams, microcytic hypochromia, elevated inflammatory markers like erythrocyte sedimentation rate of 75 and C-reactive protein 188, and TB gene expert again negative. Sputum gram-site showed pus cells and calcium was 7.8. Despite giving a cephalosporin, sulbactam, and azithromycin, there was no failed to bring any clinical improvements, or inflammatory markers were on the same trend. Hence, a CT thorax was done, which was suggestive of organizing pneumonia. You can see bilateral air opacities with the bronchogram with mild traction bronchitis predominantly involving upper lobes. So CT reported as organizing pneumonia. So workup was started and multidisciplinary opinions were taken from rheumatology and pulmonology. Cultures by that time cultures were reported sterile. So bronchoscopy was done as a part of workup, and BAL was sent for TB. TB was again negative. Gram sign showed pus cells. Routine showed 300 WBCs with 70% granulocyte, and fungal stains also negative. So then history was reanalyzed. There was an X-ray taken back where she was diagnosed with ulcerative colitis. The X-ray you can see it is taken in November 2025. X-ray was there was no consolidation in the upper lobes. So then consider the diagnosis of drug-induced organizing pneumonia. Hence, mesalamine was withdrawn and started on steroids. After 3 days of drug interruption, a surprisingly good clinical recovery was noticed and downtrending inflammatory markers. So she got discharged with oral steroids on day 10. On follow-up at OPD after 2 weeks, she is clinically better able to do routine works. Dyspnea was better. CRP was 2.1. Improvement of chest imaging. You can see the X-ray was repeated after 2 weeks. It was repeated. There was a resolving consolidation. So she was advised to continue oral steroids for 1 more month, and mesalamine rechallenge was not given because there was severity of dyspnea during presentation, and she was in remission. So this is the timeline. She was diagnosed with ulcerative colitis in October 2025 and started on mesalamine. Then symptoms gradually started from December 2025. In Jan 2026, diagnosed with a drug-induced lung injury and offending agent withdrawn, and there was clinical improvement. So why it's not interstitial lung disease secondary to ulcerative colitis? Mostly the ILD will be secondary to ulcerative colitis, mostly involve lower lobes. Usually it occurs after years, and there was no other extraintestinal manifestation. She was in remission, and there was improvement upon drug withdrawal. So now we'll discuss about mesalamine-induced lung injury. The first report of mesalamine-induced pulmonary adverse effects in the course of IBD was described in 1991. Many cases were reported, fewer than 50. 6 documented during drug-induced organizing pneumonia. It can occur between 5 days to 44 months. The pathogenesis is unclear. It is immune-mediated type 4 hypersensitivity. Mostly in chest imaging, you can see interstitial infiltrates, consolidation, or either pleural effusion. You will notice a resolution of clinical symptoms and a radiological finding usually within days or week from mesalamine discontinuation. You should always rule out other causes when you diagnose with mesalamine drug-induced organizing pneumonia. Usually the management will be withdraw the drug or plus or minus steroids upon severity of symptoms. Now we discuss about organizing pneumonia. It is an entity which comes under ILD of unknown cause. It is defined pathologically by presence in the distal airspace of granulation tissue progressing from fibrin exudates to loose connective tissue containing fibroblasts. It's not a true pneumonia, which is not alveoli is not filled with pus or any infection. It's an inflammatory process. Classification: organizing pneumonia of determined cause, which is infection either bacterial, fungal, or well, it's the most common cause of OP with determined cause, and drug-induced drugs like amiodarone, methotrexate, mesalamine, and biologics like infliximab, nitrofurantoin, and radiation-induced. Organizing pneumonia of unknown cause occurring in specific context, which is secondary to connective tissue disease like rheumatoid arthritis, Sjogren's, systemic sclerosis, and it can occur in post-lung transplant patient. There is other classification, cryptogenic organizing pneumonia. Usually the onset of symptoms will be subacute in nature. Mostly patient comes with cough is the main symptom, mostly non-productive. Other symptom will be dyspnea on exertion, fever, malaise, weight loss. On examination, they might be having crackles. Usually when you diagnose with organizing pneumonia, you have to exclude other causes by doing bronchoscopy and BAL and other workup according to the cause. Imaging, chest X-ray, CT thorax, pulmonary function test usually reveal a restrictive pattern. In bronchoscopy and BAL, there will be mixed pattern, mostly lymphocyte predominant and decreased CD4 CD8 ratio. and there will be elevated inflammatory markers like erythrocyte sedimentation rate or C-reactive protein. Biopsy is not mandatory, but biopsy show intraalveolar buds of granulation tissue with fibroblast and loose connective tissue. Management corticosteroids depends on symptom. Mild symptoms, no need to start steroids. If the patient is having severe dyspnea on exertion, start on corticosteroid. British Thoracic Society recommends 1 mg per kg per day prednisolone. You continue for 4 weeks on the same dose, then you reassess the symptom, and then you taper it to 0.5 mg per kg until 6 months. If the patient presents with a respiratory failure, then you can give IV methylpred as pulse therapy, 1000 mg for 3 days. Then you taper to oral prednisolone. If the patient is presenting requiring mechanical ventilation, then also you consider IV methylpred as a choice. If the patient has relapsed despite steroids, then you can consider other immunosuppressants like azathioprine. So the take-home message is diagnosis of drug-induced lung injury is challenging for physicians. Not every upper consolidation is tuberculosis. So possibility of drug-induced lung injury should be fully considered when unexplained respiratory symptoms are developed during mesalamine therapy. So the great imitator imitates again, but this time it's not TB. Thank you.
Thank you, Dr. Vijay. That was an excellent presentation. Yeah, this case came to me into the OPD, and they showed me the X-ray first. They said, we have a breathing problem and this is our X-ray. I looked at the X-ray and said, okay, it is TB. Okay, you go get the TB test done and come. Tomorrow we'll start on ATT. That was my first diagnosis because it was so obvious. Patient has got upper lobe consolidation, and there's some weight loss, and she was on, she has a case of ulcerative colitis. Probably she was on immunosuppressants or something. So next day she came, TB was negative. So I said, okay, we'll admit you and we'll see again. So I thought of doing a bronchoscopy and getting a BAL and send for TB. But I again sent one more TB. I was so sure that I'll get the TB, the second sample. I sent for the gene expert again, and there was no TB. It was again negative. Then I called the pulmonologist. I said, we'll do a BAL and we'll get the TB and we'll start around ATT. He also was like, yeah, this looks like TB. Again, we did a BAL. We got the gene expert, again negative. That's when we went back to the history. That's when the first time we was like, okay, sure, this doesn't look like TB. This is something else. And you see ulcerative colitis, ILD we have seen, and it's always, almost always, it's lower lobe. It's not upper lobe presentation. Then I went back and read into the literature, and surprisingly I found that mesalamine can cause this sort of picture. There were cases where there was upper lobe fibrosis, means upper lobe involvement, not fibrosis, upper lobe involvement and peripheral involvement. So that is the classical presentation where we can see in mesalamine induced drug injury. And surprisingly, I just wanted to try that out. So I just stopped the mesalamine. I didn't even start on steroids. I just stopped the mesalamine, and within 2 days, the patient was symptomatically better. Patient was not able to walk to the bathroom till that time. And just by stopping mesalamine, without even giving steroids, patient started going to the bathroom. She said, wow, this is a good change. Because she was not happy with mesalamine from beginning itself. And she said, and actually patient gave us a clue that mesalamine was the probable cause. So yeah, luckily something I got to learn from this case. I hope lots of you senior physicians and all would have seen drug-induced lung injury. So if you can enlighten us on your experiences, it will be nice.
Thank you very much for the nice presentation. We know about busulfan and other drugs, but then upper lobe specific fibrosis, I am hearing for the first time. Whenever in India we see upper lobe lesion, our standard diagnosis is tuberculosis. But repeated gene expert being negative, what you have done is a fantastic job, I would say, because you probed further many physicians, even now, will start these patients on ATT. And we don't know what interaction will be there with rifampicin and mesalamine. We don't know. We have to check. So very good case. And as an example, going PG, I have a small suggestion. In any patient with respiratory disease, when you present the case as a long case, always mention about past history of COVID. As we always used to say, no history of tuberculosis and all those illnesses. Now that is the thing. So please mention about any history of COVID in the past, because COVID can affect any organ in many ways. We used to say in the 1950s, if you know syphilis, you know half of medicine. And in the 1980s, if you know HIV, you know half of medicine. Now we say if you know COVID, you know half of medicine. That's one small suggestion. Thank you, doctor.